All right, everyone, we are here for renal failure. I actually stayed after class and we're just recording this to an empty room, so I may ramble a little bit more because there's nobody falling asleep to keep me honest. So, renal failure, we're going to talk about two kinds. We're going to talk about acute kidney injury, which is also called acute renal failure, and we're also going to talk about chronic kidney disease. So those are two very different processes here. So we're going to first, this is where in the previous lectures, if you started with the previous lectures, we kind of bypassed the renal jobs sign. Here we're going to stick with the renal jobs for a minute and talk about each job in detail so that you can understand the signs and symptoms that you're going to see when you get into renal failure. So we're going to have a slide on each one. Again, this is background pathophysiology. We are looking at their first job of waste excretion. So if you had had this slide, you probably would have understood a little bit more about the glomerulus when we talked about glomerulonephritis in the urinary lecture. If you haven't gone to the urinary problems lecture first, then you're going to get all the right anatomy. But glomerulus is the first stop. When the blood gets into the kidney, it gets filtered into multiple nephrons. We have tons of nephrons between two kidneys. I think that it counts in the millions of nephrons. Each nephron has a glomerulus, a proximal, a distal tubule, and a collecting duct. So each nephron, we're talking about millions of these between the two kidneys. We can actually go down to 10% of one kidney before we start seeing symptoms. So you can see that we have a lot of, time before our kidneys start to fail. Now, as we get older, so people living into the 80s, 90s, 100s, they're going to have not as good kidney function because their nephrons have been destroyed just by general life and their kidney function is not as great. But we really don't see signs and symptoms of kidney failure until we're down to really about 10%. So if we had 1 million nephrons to start with, when we get down to about 10,000 nephrons. So we have a lot of overkill in our kidneys, and we can actually lose an entire kidney as long as the other one is functioning. We're going to do okay, and we're not going to show signs of failure. So there are a lot of, what's the word I'm looking for? Replication or duplication of labor. But anyway, all the blood in your body will filter into these 1 million nephrons, but they go through a glomerulus. No matter which nephron they end up in, they're going to go through the glomerulus. In the glomerulus, all the solutes from the blood are pushed into the urine, basically. But not everything leaves the body right away. So the body pushes everything out. It's kind of like cleaning out a closet. You're going to dump everything out of the closet and then put back what you need, which is what exactly happens in the glomerulus. So everything leaves, glucose, proteins, everything except actual blood cells. And then the body will reabsorb what it needs back in. So very similar to cleaning a closet. You need a systolic blood pressure of at least 90 to push the stuff out of the bloodstream into the glomerulus. So if your blood pressure is less than 90, you are not adequately filtering your urine. So just a little side tidbit. Once everything's been pushed out, then the kidney nephron starts to reabsorb stuff. In the early stages, it reabsorbs everything that it's going to need for life, which is glucose and proteins. Glucose and amino acids are our building blocks. Glucose is our main energy source, and amino acids are the building blocks of life. They're what everything is made out of. So we're not going to get rid of proteins and glucose. We like proteins and glucose. We need that to survive, so the body pulls those back in. Then in the loop of Henle and the distal tubule, we start to filter electrolytes that we might need, hydrogen ions, bicarbonate, all those things that we need to balance our electrolytes, to balance our acid-base balance. That's all happening later on. And then in the collecting ducts is the last chance to reabsorb some water. And this is where, so we'll have a slide on each one of those. The second job of the kidney, so the first one is just making waste, getting rid of things the body doesn't need and bringing back things the body does need. The second job of the kidney is to help manage blood pressure. We talked a little bit about this in the other lecture when we were talking about renin. Renin is the hormone secreted by the kidney, and that renin is In a normal kidney, the renin is only produced when you have dehydration or a low blood pressure. So again, in a normal kidney, we only produce renin when we have a low blood pressure or are dehydrated. So in a normal kidney, if you become dehydrated, the kidney senses the fact that there's not a lot of blood flow, will release renin, and renin sends itself through a whole system. Renin leaves the kidney and then converts into angiotensin and aldosterone. Angiotensin is a vasoconstrictor, going to take those arteries and squeeze them down to give you a blood pressure, and then aldosterone. So you're going to turn into angiotensin, which is a vasoconstrictor, and aldosterone, which stimulates water and sodium retention. So if you are dehydrated, your kidney's going to keep hold of water. And aldosterone is going to stimulate your kidneys later on in that collecting duct and in that distal tubule to say, aldosterone's here, I'm here to hold on to water, give me all the water. And so you pee out less and it gets retained in, which makes sense if you are hypovolemic. That's an appropriate response. If your blood pressure is low for whatever reason, the body will hold on to fluid, which helps plump up the blood vessels, and will also vasoconstrict down so that you get a good pressure in your blood vessels. So that is what the kidney is doing. It can sense dehydration and low blood pressure, send out renin to increase your blood pressure. If there is a damage to the kidney or the glomerulus, now renin is being released inappropriately, which can cause high blood pressure and over retention and over sodium and water retention. So it becomes a bad thing in a damaged kidney. So that's going to be a big thing that happens to most of our kidney failure patients, is this wrong release of renin, basically. The kidney also, and this is just a more complicated slide of where everything happens in the body. Again, renin is released by the kidney. It turns into angiotensin to vasoconstrict and aldosterone to retain sodium and water. There is also another feedback system in the kidney for if your blood pressure is high to the point that it is damaging the glomerulus. So again, we need a pressure of 90 to push things out into the glomerulus. Now, if the blood pressure gets too high, the kidney is supposed to release prostaglandins, which reduces the blood pressure in the kidney. Prostaglandins don't decrease your blood pressure overall as big. It's really more of a localized decrease in blood pressure. It's just trying to save itself. And it's just like, okay, I can save myself by dilating my own vessels and decreasing the pressure in my glomerulus because I don't want to pop and explode. So these prostaglandins do help regulate the blood pressure in the kidney. The reason that non-steroidal anti-inflammatories or Motrin and those sorts of things are not good for the kidneys is that non-steroidal anti-inflammatories decrease prostaglandin productions. So that does affect the kidney. In fact, that the kidney cannot regulate its own pressure anymore, and then you end up with a higher kidney blood pressure, and it can't reduce the blood pressure in its own kidney, and a high pressure in the kidney can cause damage to the kidney. So that's why non-steroidal anti-inflammatories are bad for the kidney, because they block prostaglandins, not allowing the kidney to relieve pressure on itself. So another fun fact for you. Kidneys are also they're the main job in maintaining your metabolic pH level. So your lungs do help control things with CO2. CO2 is an acid. So when you have too much CO2 circulating around your body, or too much acid in your body will blow off. Your lungs will blow off CO2. When you don't have enough acid in your body, your lungs hold on to CO2. The kidneys are there for more of the metabolic acidosis and alkalosis. So if you have too many toxins or acidic blood products or acidic waste products or too much acidic ions in your system, the kidney will pee out those ions. So if you're in an acidotic state, the kidney is supposed to pee out hydrogen ions, which are acidic, get rid of those hydrogen ions, get rid of those waste products, and then it makes more bicarbonate. The kidney actually can make bicarbonate And so when you're in an acidotic state, it will release some acidotic ions and then hold on to bicarb, because bicarb and acids in the bloodstream neutralize into water. So bicarb is our body's natural neutralization, or our natural Tums for our bloodstream. Bicarbonate is what the kidney will release to absorb any of that acidity. So when your body is in an acidotic state, the kidneys kick in to pee out stuff you don't need and to increase its production of bicarbonate. If you are in an alkalotic state, or you are too alkaline, it will excrete bicarbonate and it will hold on to acids. So that is one of its jobs. The other job, of course, is electrolyte balance. That's what the loop of Henle is doing. It's managing your potassium, magnesium, calcium. They've got lots of sensors in there and are trying to keep things at a normal level. If you have too many, you will pee them out. If you have too few, you'll retain whatever ions you have. So the kidney is in charge of holding on to electrolytes that we may need, but also the kidney is involved in your vitamin D production. Vitamin D that you absorb from the sunlight or your diet is not a usable form. You could take all the vitamin D pills you want, but if you cannot convert it, and one of the conversion steps is in the kidney and one of the conversion steps is in the liver. So in order to have high vitamin D levels or adequate vitamin D levels, you need to have a working kidney and liver to turn the vitamin D into an active source. So one of those is in the kidney. So when kidney failure patients, when your kidney starts breaking down or failing, your vitamin D levels will go down as well. So another fun fact for you. The last job is fluid balance. The kidney can detect low levels, high levels, and again, it will help with blood pressure. But the last spot is your collecting ducts. This is your last chance to absorb water. So the glomerulus and the proximal and the distal tubule are all reabsorbing water. But this is your last chance for your brain to have an input on whether you should reabsorb water or not. And if the brain is in a dehydrated state, it will put out this antidiuretic hormone, which means don't pee out water. And so if your brain is asking for water, it will stop, it will produce this antidiuretic hormone. And then in the collecting ducts, the kidney will hold on to more water in response to that. This becomes important later when we talk about endocrine, because there's an issue with this antidiuretic hormone. But really all the kidney's job is to respond to this antidiuretic hormone. And antidiuretic is don't pee. Diuretic means pee. Antidiuretic means don't pee. So if you have a lot of don't pee hormone, you're not going to pee out a lot of water. You're still going to pee out waste, but you're going to hold on to all your water. And if the brain is like, nah, I'm good, we can let water go, then your levels of antidiuretic hormone drop and you pee out more water. So that's the last job of the kidney, is really to do that fluid balance. Oh, sorry, that was the second to last job of the kidney. So blood pressure, acid waste, fluid waste excretion, water excretion or holding. And the last part is red blood cells. You'd be like, why in the world is kidney involved in the red blood cells? Well, it's a sensor. The kidney, that glomerulus, is a great sensor. It can sense blood pressure and release renin. If it senses a low oxygen state, or the fact that the hemoglobins are not fully oxygenated, it will send out erythropoietin. Erythropoietin is the stimulus for the bone marrow to make more red blood cells. So if it senses hypoxia or a low red blood cell count, the kidney will send out the hormone to the bone marrow and say, hey, make more of these. I just noticed that there aren't any as they pass through, and so make more of them. So patients that have kidney failure, they do not make adequate red blood cells. So you may find out that a lot of kidney failure patients are anemic, and that is because one of the kidney's jobs is to keep tabs on our blood and let us know when the red blood cell production is not adequate. So when the kidney isn't adequate, neither is your red blood cell production, and most renal failure patients are anemic in some kind. So you've already learned so much just from learning the 6 jobs of the kidney, but we're going to take you into acute versus chronic kidney disease. This is a brief summary slide to kind of tell you the difference, and then I'm going to go into the acute kidney injury, and then we will go into chronic kidney disease. So the very big difference is that acute kidney injury happens over hours to days, and it is an acute and treatable cause. There are 3 kinds of acute kidney injury. You can have acute kidney injury no matter what age you are, no matter what you have going on in your life. You can always have acute kidney injury if you have one of the 3 reasons for acute kidney injury. Those are pre-renal, intrarenal, and post-renal causes. So if you have any of the pre-renal, intrarenal, post-renal causes, you are at risk of an acute kidney injury. And that is something that we'll delve more into detail. Chronic kidney disease takes months to years to develop. And again, like I said, you're going down to 10% of your kidney over months or years. It's usually caused by unmanaged chronic conditions, the most common being hypertension, diabetes, or acute kidney injury that we couldn't fix in time to reverse it. Those are our most common causes of chronic kidney disease. So acute kidney injury can turn into chronic kidney disease if we don't reverse it. Most acute kidney injuries are reversible. If they don't get reversed, they can become chronic kidney disease. Otherwise, the most common are hypertension and diabetes that cause long-term damage to the kidney. So that is your quick, just the 2. Let's talk about each one. Acute kidney injury. This slide looks busy, but this talks about the stages of acute kidney injury. So acute kidney injury, remember, this is something that happens acutely. It has 3 causes, 3 possible causes, which encompasses many, many different problems and diagnoses. But your first stage of acute kidney injury is anything that decreases perfusion, damages the kidney, or blocks the kidney from functioning. So almost every single one of our urinary problems is stage 1 of an acute kidney injury. If we don't fix these urinary problems, your patient will then move into stage 2, which is where you have signs and symptoms of acute kidney injury or acute renal failure. So stage 2 is where we see signs and symptoms. Stage 1 is just the risk factors. So we do spend some time on these risk factors because identifying risk factors for acute kidney injury is where you can intervene and prevent acute kidney injury from happening. Once you are in acute kidney injury, you are considered stage 2 of acute kidney injury, and that is the stage where you see symptoms. So let's talk about the risk factors for acute kidney injury. Move on. So the cues of this, there are no real lab cues for acute kidney injury in the first stage. In the first stage, they are just risk factors. The reason we want you to know these risk factors is that we can intervene and mitigate further kidney damage by fixing these factors when they happen. So stage 1 of acute kidney injury, they have no real symptoms. They only have risk factors. They may have a completely normal BUN and creatinine, but we need to keep following because if they have these risk factors, we're considering them stage 1 of an acute kidney injury. So we had better be monitoring our kidney numbers, which is our BUN, creatinine, and glomerular filtration rate, to see if our kidneys are progressing into a worsening stage or stage 2 of acute kidney injury. So our risk factors are inadequate blood flow to the kidneys. So for some reason, the kidneys are not getting blood flow. That could be dehydration. It could be hypovolemia, could be just hypotension, could be blood loss, could be decreased cardiac output. The heart's not pumping well enough to supply blood. So for some reason, the kidneys aren't receiving enough blood to nourish itself, much less do its job. So decreased perfusion to the kidneys can cause acute kidney injury. Now, the kidney in response to decreased perfusion is going to secrete renin appropriately and try to maintain by retaining water and retaining sodium. But if the hypotension, dehydration, blood loss is too much for it, or the cardiac failure is too much, renin is not going to fix the problem. And so when the kidney can't fix its own problem with secreting renin and getting that system working, then it slowly starts to waste away. So inadequate blood flow to the kidneys is our first risk factor. So of course, if if we have inadequate blood flow to the kidneys for one reason, we're usually trying to fix that. If they have a low blood pressure, we're probably trying to get them a blood pressure. If they have hypovolemia or dehydration, we are probably trying to fix that. But if the patient isn't seeking medical assistance until too late into a low blood pressure or a dehydration or a low perfusion state or heart failure, if they're not seeking help for this, they can be in stage 1 of acute kidney injury, and then we notice it when they're already in stage 2. We have to be able to intervene in this early stages. People ask me how long this first stage can last. The first stage can anywhere be from hours to days, but it's usually within 24 hours of the pre-renal, intrarenal, post-renal problems that we have a good intervening window. So 1 to 2 days is usually stage 1. Then once we start seeing symptoms, we're calling it stage 2. So there is no set for how long the first stage lasts. It depends on the degree of decreased perfusion and how long the kidney can tolerate that. So that's the pre-renal cause, is decreased perfusion to the kidney. Pre-kidney, not involving the kidney, but damaging its flow to the kidney. Intrarenal is actually direct damage to the kidney, whether it's from an infection or a toxin to the kidney. The most common causes of intrarenal are actually renal infections that we talked about, like glomerulonephritis, urinary tract infections, pyelonephritis. Those renal infections can physically damage by letting bacteria or virus damage the kidney. You can have nephrotoxic medications, which are medications that are toxic to the kidney directly. I do have a slide on that in just a second. Acute hypertensive crisis, which means that you are in a crisis, usually a blood pressure of over 200 over 110. This can actually physically damage the glomerulus and cause intrarenal injury, can damage the glomerulus, damage the tubules nearby, because this high pressure, it actually damages the tissue of the kidney. And then any kind of thrombolytic disorders. So things like sickle cells, like these sickle cells get stuck in the tubules, blood transfusion reactions, these complexes basically stick in the tubules, stick in the blood flow around the tubules and damage the kidney function. So intrarenal means actual damage is being done to the kidney. Postrenal means there is an obstruction to kidney outflow. So all the things we talked about that were obstructions, renal stones, BPH, cancers, tumors, scar tissue, anything that is impeding the kidney from being able to dump urine into the urinary tract is a obstruction or a post-renal cause. So any of these causes, if they are left untreated for a couple of days, are going to cause stage 2 acute kidney injury. So there are no signs and symptoms. People may or may not seek treatment for it. They may or may not recognize that they are in stage 1 of acute kidney injury. But every patient with renal stones, with an obstruction of some kind, with BPH, is in that risk stage. And we need to treat their problems in order to avoid acute kidney injury getting worse. So stage 2 of acute, well, we're going to keep going through stage 1 before we talk about stage 2. The kidney pharmacology, these are nephrotoxic medications. Yes, put these in your memory bank. Nephrotoxic medication should be always, we should be monitoring the BUN and creatinine around these medications because they can directly damage the kidney. Antibiotics, almost every antibiotic has some ability to damage the kidney because they are pretty toxic. They're going to kill bacteria, but they are actually toxic to the kidney as well. So antibiotics, antivirals, please just keep an eye on your BUN and creatinine around them to make sure that you're not getting intrarenal problems. Chemotherapy is extremely toxic to the kidney. Radio contrast media, which is dye for CT scans and angiograms and those sorts of tests. Radioactive contrast is very toxic to the kidney, and actually proton pump inhibitors are toxic to the kidney. When you are giving a nephrotoxic medication, you have to watch your kidney function and also flush these medications with lots of water so that they cannot they are diluted and don't damage the kidney as bad. You may have heard that there are some medications that non-steroidals are not good for the kidneys. Diuretics are not, well, they aren't very good for the kidneys because antihypertensive medicines, if you take too much of them or they lower your blood pressure too much, can cause pre-renal problems. Diuretics can cause hypovolemia, which is a pre-renal problem. And non-steroidal anti-inflammatories block prostaglandin production, meaning that the kidney is allowed to get pressure a little bit too high in the kidney, and then that causes an intrarenal damage as well. So we want to be careful, especially with a patient that already has a pre-renal, intrarenal, or post-renal cause, that we use non-steroidals, antihypertensives, and diuretics with caution, making sure that we're not reducing blood flow to the kidney. Because if you're already in a risk factor and then you add a risk factor medication to it, we've doubled our chance of going into stage 2. Stage 1, we are just going to monitor everything and make sure that we are treating the underlying cause, but also watching our urine output, our lab work to look for a worsening condition, knowing where our fluid volume is, knowing what their edema is in that stage 1 will help us identify if they're moving into stage 2 or not. The big treatment for this is eliminate the cause. So if you are pre-renal or decreased perfusion, we would want to give IV fluids to treat dehydration, treat blood loss, treat any heart failure conditions. If you have an intrarenal risk, maybe you've gotten a nephrotoxic medication, radio contrast, we want to reduce or remove that. And if we cannot avoid giving it, like if you can't avoid contrast, so if you cannot avoid giving the nephrotoxic medications like contrast, you will need to flush those toxins. So patients getting radio contrast will usually get IV fluids or be encouraged to drink tons of fluids afterwards to flush that toxic contrast, avoid them from damaging the kidney. And of course, if you are having any obstructions, one of our major interventions for any of the obstructions is going to be to bypass the obstruction, or if you have a high risk for an obstruction, to monitor for a decrease in urine output so that we can know if the obstruction is starting to cause backup to the kidney, and if that obstruction is causing backup to the kidney, could cause kidney damage and acute renal failure. So we are going to bypass that obstruction with usually a Foley or some kind of urinary drainage device, whether it's a nephrostomy tube, or a ureter catheter, something, or a ureteral stent, something that's going to bypass that obstruction and allow urine to escape the body so that we do not end up causing that kidney to swell and become damaged. So eliminating the cause is the key interventions for treating acute kidney injury. It's also the key interventions for treating your pre-renal, intrarenal, and post-renal problems. And if a patient has been in acute kidney injury, they will enter so I don't think we went through the multiple stages here. If you're in a stage 1, basically any patient that has a low blood pressure, low perfusion, taking nephrotoxic drugs, in with a kidney infection or in with an obstruction, they are in the first stage of acute kidney injury, and they need to be educated that if this condition persists or comes back, the low perfusion, the nephrotoxic drugs, the infection, or the obstruction, if these conditions come back or persist, they may end up in second phase of acute kidney injury, and that is important for them to know what they can do to help them prevent this. Avoiding dehydration, maintaining adequate urination. They should know to ask their physician if they've been in acute renal failure or at risk for chronic renal failure or at risk for any kind of failure. Ask about nephrotoxic medications. When a physician prescribes a medication, they should we will, in the hospital, as their nurse, taking care of them, do the due diligence to help them avoid or lower the dose of or flush nephrotoxic meds. But the patient also needs to know to avoid nephrotoxic medications and ask their provider if any of their medications could damage their kidney, because they're the ones protecting their kidney if we are not available to protect to help them protect their kidney. Since low perfusion can cause renal failure, managing their heart failure, managing their blood pressure, staying out of acute hypertensive crisis, managing their obstructions if they have a BPH, maintain their medications so the obstruction does not cause weak flow or no flow. And then any signs or symptoms of renal failure like weight gain or edema or shortness of breath, whenever they're holding on to fluid, that's a sign that the kidneys really aren't doing what they're supposed to be doing. If they're floating onto excess fluid, and that should be something they communicate with their physician about or their nurse or let you know. The second stage of acute kidney injury is where we actually have some kidney damage. And this is where it could happen anywhere from 1 day to a week after the cause of the acute kidney injury. So a pre-renal, intrarenal, or post-renal cause. So if you have glomerulonephritis that does not get under control within 2 to 3 days, you could move into acute kidney injury stage 2. If you have low blood pressure or heart failure that cannot be managed within a day or two, they will start ending up with permanent damage to their kidney. So we want to make sure that we manage these conditions when they are in stage 1. If these causes cannot be reversed, or it's going to take time to reverse them, they may end up having some damage to their kidney. And that will show up as increased BUN and creatinine levels, the beginning of fluid volume retention. You may start to see edema form in these patients. You may start having electrolyte imbalances. But the biggest one that we are looking for is a lack of urine output. And we will be monitoring those if you have low flow or an infection or a obstruction. You're going to be watching their urine output, because that is the biggest cue that we have moved beyond a risk factor to actual kidney damage. Usually the first sign would be the increased BUN and creatinine, but if you're not following those, you will start following them when your urine output drops. But when the urine output drops, you've already passed stage 1. You're into stage 2. Stage 2 is actual kidney failure. It's the acute kidney failure side of acute kidney injury. So if you think of first stage as risk factor, second stage is actually having acute kidney injury, third and fourth stage are healing. So we usually, if we're following them in stage 1 with their BUN and creatinine, we may see the BUN and creatinine start to climb before we drop our urine output. We should be concerned when we start seeing excess waste products not being excreted from the body. That is a sign that the kidney's trying to tell you, I can't handle my workload. And the later sign is the urine output dropping off. Once the urine output drops off to less than 0.5 milliliters per kilogram per hour, I fixed it on this slide, or less than 424 hours, you can use that 30 milliliters an hour. 30 milliliters an hour for 24 hours, though, is like 600 milliliters. So if you're worrying about your patient at less than 30 milliliters an hour, it's still a good guideline, but the official guideline is 0.5 milliliters per kilogram. If you don't get a weight on an exam, or you don't have a weight on your patient yet, you can go with 30 milliliters per hour, but it is more accurate once you have a weight to be worried if it starts dropping less than half a milliliter per kilogram. Once they are in this oliguric phase, which means their urine output is decreased, if it continues to have, if you're still not treating the kidney damage, or you can't treat the kidney, they will worsen through kidney failure. This acute kidney injury can stop at the early existing stage 2, or it can progress into a worsening stage 2. There is no, stage 3 and stage 4 are not worsening conditions, they're healing stages. So the actual failure, the acute kidney injury failure, happens in stage 2. So we have the injury. Think about the existing cues as injury. So I'm going to put that there. Let's call this as injury to the kidney. The injury is finally showing up, and the worsening cues are the kidney is failing for this acute cause that we can't get under control. So if that helps you understand that injury is, you're in second stage, here they are, and then as second stage worsens, that's where we consider it acute kidney or acute renal failure, or acute kidney failure. This is where, when the kidney fully fails, it's not completing its job requirements, so you end up metabolically acidotic. It can't maintain your acid-base balance. Your electrolytes are out of balance. Your fluid balance is out of balance. You get fluid edema. You get arrhythmias.
they may end up with an anemia. Any of the kidney jobs that are not working can worsen in stage 2. So if we think of stage 2 as the actual injury showing up and possibly progressing to failure if we can't get that injury under control, that is what stage 2 looks like. Move on. What are we going to monitor? We're going to keep monitoring the same things we monitored in stage 1 when we had a risk. We are going to watch our urine output. If our urine output has dropped off to nothing, we're looking for it to either come back or respond to treatments that we give to try and get some urine output out of the patient. We are certainly going to watch our BUN, creatinine, and electrolyte levels. If you are in the renal failure part of it, then they start watching ABGs, or the serum CO2, because that's going to help us manage their acid-base imbalances. For fluid volume, this is where once you start showing signs of edema, we are going to monitor that edema closely. If you are not putting out urine or not putting out adequate amounts of urine, that fluid's got to go somewhere, guys. And where's that fluid going to go? That fluid's going to go into the tissues. I'm going to draw my little vascular diagram here. So let's draw our little blood vessel here. And we're going to put a ton of fluid in it because our kidney stopped working. And so we have so much fluid that we can't pee out. So it is sitting in this blood vessel. And if you are sitting in that blood vessel, where is fluid going to go? It's going to go to the cells first. That's where it's most attracted to until they are full. Once they are full and will not accept any more water, then the fluid is now going to seep into that interstitial or that third space and start causing pitting, tissue edema. So think about when your kidneys are not getting rid of the fluid, we still have fluid in our body. It's got to go somewhere. And where it is going to go is going to be into the interstitial space. The last place that fluid will go, it tries to fill up the cells first, then it tries to fill up the interstitial space, and one of the interstitial spaces that it does fill up is the lung tissue. The lung tissue is super, super thin right there at that alveoli. It's for oxygen exchange and CO2 exchange, but since it's only one capillary thick and it's a very thin membrane, fluid can easily whoosh across it. When the blood vessel running by the alveoli is packed full of fluid and it sees an empty space, an empty air-filled space, it's going to go there. If it's under high pressure and super, super full, so again, I'm just going to draw my vessel. Let's draw the alveoli this time instead of cells. Let's draw our, let's go back and make the alveoli a little bit bigger. So this is our lung alveoli. We've got a lot of air-filled sacs here, and we have a capillary that's one cell thick. So if you have red blood cells, they're marching by and they're exchanging gas. And they're exchanging CO2 and O2, and they're doing their jobs. But now we've got all this fluid in here. This fluid's packed around the cells. Well, that fluid is saying, wow, look at all that air-filled space. I can get out of this high-pressure tunnel, and I'm going to go in there. And once the fluid starts sitting in the alveoli, we end up with fluid in our lungs. Get crackles, and I'm just going to put a little thing off. I'm going to tell you again in respiratory multiple times, but where do you hear crackles? In the lungs. So I'm going to draw, let me just go to a little whiteboard here. I'm going to step off for a minute, and I'm going to draw a little whiteboard here, and I'm going to draw your lungs. So let's draw your lungs. This is a very crude drawing of your lungs here. And around your lungs is a ton of, let me draw, where's my colors? I got to change colors here, guys. We got to make this somewhat accurate. I can't figure out where my colors went. Well, all right. Can't find my colors. Let's draw the blood vessels around all these little alveoli here. So these blood vessels. And imagine these pulmonary blood vessels are pretty thin. And they're only about one cell thick. Where are my colors? Okay, I found them. So here are our colors. Let's draw these blood vessels going around our lungs. And they are supposed to be exchanging oxygen. So we've got this blood vessel, and we've got our red blood cells parading around and exchanging oxygen and CO2. But now our kidneys have decided to stop working. So there's a ton of fluid hanging around in this system too. So we're going to just stuff these blood vessels full of fluid because it's never escaped our body. And so these blood vessels are chock full of fluid. So we're going to just chock full these guys so that the pressure in these lung arteries and veins is really high. And all this fluid wants to escape into this air-filled space because they're under high pressure in the vessel. So let's escape the high pressure and go to a place of low pressure. It's kind of like moving to Montana when you live in Los Angeles. You know, get out of that high pressure system and go to somewhere that's got a lot of space to roam around. So the fluid's sitting in here. Now, when you're sitting upright or you are standing upright, fluid is dependent and it's going to sit at the base of the lungs. So when you listen with your stethoscope, you want to listen to the base of the lungs because fluid is going to collect in the base. So if this is your stethoscope, that looks like a kind of an upside down dead stick person. Let's get rid of him. But you're going to listen to the bases of your lungs, and the best place to hear the bases of the lungs is in the back side of your lung space, so on your back at the base of the lungs. So right up at the, because in the front, you got your stomach and your intestines and all those things kind of stuffed in front of, and your heart's sitting right in front of the base of your lungs. So on the front side, you're not going to hear these crackles. You're going to hear these crackles on the back side of your back when you're listening to your lung fields and at the bottom of the lung fields. When do you think you're going to hear these sounds? At the beginning of inspiration, the end of inspiration, exhalation. You're going to hear them. The sound of crackles is the sound of air moving through fluid. And when you take a breath in, if you're taking shallow breaths in, you're only getting air to the top parts of your lungs. So you're really only going to hear crackles at deep inspiration, at the very end of inspiration, when your lungs are the fullest of air that they can be, and that fluid is now that air is now pushing through the lungs, through the fluid down there at the bottom, and so you hear the crackle. So you hear your crackles in the back, at the bottom of your lung fields, at end inspiration, and inspiration. So imagine holding your breath, all that air is sitting in your lungs and it's trying to get through that fluid, and then you hear a little snap, crackle, pop. It's very quiet, almost like if you put your fingers next to your ear right now and rub your fingers right next to your ear, that's almost exactly what it sounds like. Very, very quiet, very hard to hear. But that's where you're going to listen for crackles. If this fluid gets built up even more, then we get even more escaping of fluid into the lung space, and the lungs can fill higher and higher and higher. Now the crackles get louder and louder and more easily listened to, but we're pretty far down into some pulmonary edema. So pulmonary edema happens last. It's really one of the few places that it's a very late sign of a lot of edema. Okay, I just erased my lungs, but we're going to go back to the presentation. So fluid volume, first we're going to see some generalized edema, then we're going to see probably some swelling in our lower extremities, then it becomes pitting, then it becomes pulmonary edema. So keep an eye for those things because that's how we're going to see the fluid backup progress throughout our patients. Also, weigh your patients every day. Remember we said that when fluid sits in that interstitial space, we can't measure it. When fluid is here in the vessels, we measure the blood pressure. When fluid is out in the tissues, we can measure the mucous membranes, and hopefully that's a reflection of whether our cells are going to be hydrated or not. But we have no way to measure this interstitial area. There's no way to measure that fluid. And you can say, yeah, I've got edema, but we can't put a number to it. We can't quantify it. So how we quantify interstitial edema or full-on weight is our weight gain. Did you know that 1 liter of fluid is 1 kilo in your weight? So if you are retaining a ton of fluid, your weight is going to go up. After a salty meal, your weight is going to go up because you're retaining more fluid. That's why we gain and lose about 5 pounds on a day-to-day basis, because our fluid status is changing. We're not going to worry too much about their weight going up slightly, but if it starts going up by multiple kilos, 2 to 3 kilos in a day, That's an extensive amount of fluid retention, and that fluid has nowhere to go. The weight is really the one way that we can say, yes, we have gained fluid and we're not getting rid of it. So weights are very, very important in our fluid volume status, especially without urine output to tell us what's going on in the body. Of course, you're going to look fluid overloaded. We can go by edema assessment, but we're going to go by weight as well. So as we're in the second stage, we are in oliguria or injury. We're decreasing our urine output, but we are still monitoring to see, do we stay in injury phase? Do we start improving from injury phase? So you can just have an injured kidney that starts to heal and gets better. You can have an injured kidney that continues to get worse and goes into full-on failure, having acidosis and fluid retention and no urine output, and then we'll start to heal. So I'm not sure where your patient's going to go in stage 2 of acute kidney injury, but you do need to watch them and find out, are they worsening? Are they improving? What are we going to do when they're in this stage? It's going to depend on, again, the degree of the stage that you're in, of stage 2. If you're just oliguric and you still have some fluid output, well, we're going to give you a diuretic. Now, we did put diuretics in the nephrotoxic list, because if the diuretics cause fluid depletion or hypovolemia, they can injure the kidney. Well, in a second stage kidney, we're not worried about hypovolemia on this patient. This patient's already retaining fluid. They have injured or failed kidneys. They're going to be retaining fluid. If they are retaining fluid, especially fluid in the lungs, diuretics are an appropriate option. Now, the kidney is failing. The kidney is injured and damaged, and we are going to flog it with diuretics. Are diuretics nice to the kidney? No, they increase the workload of the kidney, but we really got to get that fluid off to save our patients. So you will see patients in acute kidney failure with no urine output getting diuretics. It's because we're trying to squeeze the last bit of work out of that kidney before it fails. So diuretics are very similar to flogging a sick horse. It is not best practice, but we're doing it to manage the fluid excess. So if your patient's walking around and they just look a little puffy, that might not get you a diuretic, but if they are having trouble breathing or having fluid in your lungs, this is an airway breathing problem, they're going to get a diuretic, even if the kidneys do not really respond to it really well. And I will tell you that our normal doses of diuretics don't work in an injured or failing kidney. The doses of diuretics are going to be much, much higher. So a patient's not going to respond to 20 milligrams of Lasix. They might not respond to 40 milligrams of Lasix. They may not respond to 120 milligrams of Lasix. They may need to be on a continuous infusion of Lasix to get even a dribble of urine output out of the kidney. So we do it, but it's not helping the kidney. It is flogging the kidney. We will put them on a fluid restriction and a low sodium diet because we don't want to add insult to injury. We want to make sure that they don't get more fluid. We're already dealing with a fluid retention issue. You don't need more of that. If there is worsening cues in the kidney, it does go into absolute failure with acidosis and severe electrolyte imbalances. Then you are going to end up with sorry, I got to plug in my phone. My computer. But you will end up on temporary hemodialysis. We will talk about hemodialysis in chronic kidney disease because it is an end-stage treatment for end-stage chronic kidney disease, but it is also indicated in acute kidney failure or the worsening second stage. Because if your kidney is failing and diuretics aren't helping anymore, we got to get this fluid and we got to get these electrolytes out of your body. And the only way to remove that stuff from your body is with the hemodialysis. So they will go there, but only after they've run through all of their options. Okay, plugged in my computer. Had to pause for a second there. Remember, measure your daily weights. Daily weights are the best way for us to figure out if they are retaining fluid. It's better than blood pressure. It's better than mucous membranes because their blood pressure is already going to be kind of on the high side. But what's going to happen when the blood pressure gets to the point where the body doesn't like the blood pressure being that high? Fluid will shift out of the cells into the tissues. So your blood pressure will top out really at a certain amount. There is no right number that your blood pressure will top out at. But remember, your body will push that fluid out of the vessels into your tissues to maintain a decent blood pressure. Your blood pressure is not going to allow the vessels to explode. It will push out of the vessels into the tissues. So in order to see when you've really got a pretty on the high end blood pressure anyway, and your mucous membranes are great, your weight is going to tell you if you're retaining fluid, your weight and your edema assessment. When your patient is super edematous, they're going to skin break down very, very easily. There's a lot of fluid in between your epidermis, the top of your tissue, and your dermis, and blood flow's not getting up to the epidermis very well, easy to shear. If you've ever seen a blister pop, that's exactly what their skin looks like when they're super, super edematous. So make sure you have skin care, shift them, prevent skin breakdown, because we don't need skin breakdown and infection on top of renal failure. Make sure that your meds, if you have a high BUN creatinine, and certainly if you have failure, evaluate whether your meds are nephrotoxic and if they need dose adjustments. And of course, we want to prevent prolonged episodes of hypotension and hypovolemia, but we're really not going to have too many of those if you're already fluid overloaded. But you do want to be on the lookout if your patient is improving, that they're not going to go back into a risk factor, which is hypovolemia. So really managing your fluid and electrolyte and acid-base imbalances in the second stage. We're basically supporting the kidney and hoping to treat those underlying causes so that we can heal. And again, with the patient, preventing further damage to the kidney is important. If they are having issues with their sodium electrolytes, or they are in failure, they're high BUN creatinine, they're not putting out any urine output, we're going to put them on the renal diet. The renal diet, I do have more slides in the chronic renal failure section, but the renal diet is a waste control diet because BUN and creatinine are waste products from protein breakdown and muscle breakdown and food breakdown. And so if your BUN and creatinine are already high, let's not add more damage to the situation here. Let's not put more protein into the body that it can handle. Adequate protein, adequate calories, not a lot of extra sodium restriction, and if they can't take in enough nutrition to heal their kidney, we may give them specialized kidney enteral feeding that they can then heal from their kidney injury. So, and then they would probably be on fluid restrictions as they get into the worsening stage. Now remember, when you're just oliguric, you might not get every single intervention, but as you progress to worsening second stage, then you start getting more strict interventions. So second stage acute kidney injury goes from just an injured kidney all the way to a completely dead kidney, but the cause is an acute cause, a pre-renal, intrarenal, or post-renal cause. Then we have our third and fourth stages, which are actually, yay, good stages. They're healing stages. This means that our kidney has started to improve. There is no set stage. Basically, as soon as you have reversed the underlying cause and the kidney has had time to heal from its injury, you go into the healing stages. In the third stage, the kidneys have healed enough. So kidneys heal from the glomerulus down. So they basically, they start repairing their glomerulus first as they repair themselves. They repair their glomerulus, they'll repair the distal tubules, the proximal tubules, and then the last stage, they repair the collecting ducts. So, there's a lot to repair when the kidney's damaged or injured or failed. Remember, we can work on 10% of our kidneys. So when we're showing signs of kidney injury, kidney failure, we're down to really less than 10% of our normal kidney function. And so that's got to heal. It's going to take time. But kidneys do heal from the most important part, or from the top down. So they're going to heal from the glomerulus through the tubules and then the collecting ducts. So in the third stage, we start to see our kidney healing, meaning that the collecting ducts, the glomerulus is working, stuff's being able to get out now into filtrate. They're starting to produce urine. In fact, they produce a lot of urine, so much urine. This urine we're flushing fluids out of the body, wastes are leaving the body, our BUN and creatinine values start to improve, our acid-base electrolytes values start to improve, we're no longer holding on to everything, and we start throwing a little party. Yay, your kidney's healing, everything's great. But our collecting ducts and our distal tubule aren't all the way healed yet. So even if your body's like, whoa, put a damper on the fluid, you've gone overboard, you've gotten rid of the excess fluid and the fluid that we need to survive. Hey, start holding on to urine. That antidiuretic hormone, the kidney doesn't respond to it yet. And so the urine output can be extensive. At the very beginning, when they're getting rid of extra fluid off their body, that's great. But as they get rid of that extra fluid off their body and they still continue to put out 5, 6, 7, sometimes 8 liters a day, they can become hypovolemic. And guess what hypovolemia is? It's a pre-renal cause of acute kidney injury. So as they start to heal, if we don't monitor their fluid status and they tip into dehydration or electrolyte depletion, they can go right back to square one, stage 1 of acute kidney injury, and they can go back into their kidney injury and kidney failure. So in stage 3, you can throw a party for your patient and celebrate their new urine output and their less puffiness and their lack of fluid in their lungs, and everything's great. Just please be sure to not let them get dehydrated, because if they get dehydrated or electrolyte depleted, they may end up right back into kidney failure. So in that healing stage lasts about 1 to 3 weeks before the kidney finally puts itself all back together. And then it will go into the 4th stage where everything works perfectly. The BUN and creatinine have returned to normal, but now the kidney is going to recuperate, and it's going to try and build itself back up from the 10% function that it got back to hopefully back to some at least 50% or maybe even fully 100% function again. That takes about a year to really get those kidneys back. So patients are at very high risk of, again, going back into renal failure. So they need to watch for hypovolemia, for infections, for obstructions, for any risk factors, again, because they've really their kidneys have gone through the ringer. Let's not have it happen again. So 4th stage, there are no signs, symptoms, really. Everything's back to normal. But just so you know, when everything comes back to normal lab-wise, that just means we have 10 to 15% kidney function, because we don't have signs or symptoms till we drop below that. So of course the kidney's going to try and heal itself a little better than 10%. So that time takes about a year. And just tell the patients while their kidney is functioning, even though everything seems right, still go see their doctor, still follow up with the things, and still take care of their patients, take care of their kidneys, no nephrotoxic meds, no dehydration, stay hydrated, take care of the kidneys. So I'm going to let you take a little bit of a break, and then I will come back. So go ahead and pause it, go grab some food, go step outside, and when we come back, we'll do chronic kidney injury. So I hope you had a nice little break. Hope you got some coffee, some food, some drinks, took care of the dogs, walked the dogs. I don't know. Go out and walk around every now and then during these lectures. We're going to talk about chronic now. We talked about acute, pre-renal, interrenal, post-renal cause. They really have no other history of, they can have chronic renal failure. You can have acute on chronic renal failure. So if you have an acute cause of your kidney injury, you have acute kidney injury. And these words, injury, disease, they're all kind of interchangeable. Failure really means you're not putting out any urine output anymore, and injury means that you could still put out some, but you're pretty well damaged. If you're having signs and symptoms, you're down to function. So chronic kidney disease, chronic renal failure are kind of interchangeable. You may see people use them interchangeably, and we do use them interchangeably. Chronic kidney disease, though, is a long-term process brought on by the underlying risk factors, the most common of which are hypertension, diabetes, and unhealed acute kidney injury. But chronic kidney disease is very, very big in America and in the world because of our incidence of heart failure, our incidence of high hypertension, and our incidence of diabetes. So patients don't know that they have kidney disease unless they happen to find it on a lab work or if the doctor's following it. Because again, remember, we don't see signs and symptoms of renal injury or failure until we're down to 10% of our kidney function. So we've got 90% where we got a lot of time to lose these kidneys, and they will slowly die off until we see symptoms. So you don't need to memorize each stage and what the GFRs are. Just know that a normal glomerular filtration rate is 90 or above, And if you're less than 90, then you're starting to have some stage of chronic kidney disease. It's the only way we can see if you have chronic kidney disease is to measure the glomerular filtration rate. Because remember, again, you're not going to have increased BUN, increased creatinine, or any signs and symptoms of kidney failure or kidney disease until you're down to 10% function. So from my kidneys damaged 80%, 60%, 50%, there's no signs and symptoms. The only lab that's going to show up here is your GFR. So as patients, if they have underlying or hard to control hypertension, diabetes, heart failure, or acute kidney injury, they're going to be watching the glomerular filtration rate because that's how they're going to stage these things. So you may see in your patients' charts that they have stage 2 chronic kidney disease. And you're like, but they're not on Lasix, they're not on anything, they're not having any signs or symptoms, because there are no signs and symptoms in stage 1 or 2. There just aren't. It's only the GFR. So as we go through that, I put stage 1 and 2 kind of together because there's no signs and symptoms for them. Your GFR is normal. You have underlying conditions. That's really, in stage 1, your GFR is normal. In stage 2, your GFR has started to decrease. But that's the only signs and symptoms. The signs and symptoms are the underlying risk factors: diabetes, hypertension, coronary disease, heart failure, any kind of disease that's going to damage the flow to the kidneys. But we don't really worry about intrarenal, postrenal causes of chronic kidney disease. These are chronic diseases that cause chronic kidney disease. So you don't have to worry about intrarenal, postrenal, prerenal for chronic kidney disease. That's all for acute kidney injury. Really, stage 1 is just you got risk factors. So anyone with diabetes, hypertension, coronary disease, heart failure in their chart qualifies for stage 1. Can you believe how many people are in our world that are in stage 1 chronic kidney disease? If you have not managed these conditions to the best of your ability, whether it's your fault or not. I mean, some people with diabetes just have uncontrolled diabetes, no matter how well they try to control it. But as you progress through diabetes, you will end up damaging your kidney, especially if you can't keep it under control. If you can't keep your blood pressure under control, the kidney will become damaged. So chronically, and the worse you control these chronic conditions, the quicker you move through these stages. So stage 1, everything looks normal, you just have risk factors. Stage 2, you do have a decreased GFR, and you still have these underlying conditions. Worsening cues is moving into stage 3. So stage 1 and 2 doesn't have a whole lot you can do about it other than start to control these risk factors. So this is where we're doing a lot of teaching. The intervening is teaching, monitoring and teaching. We want to tell the patient, you're at risk. You're in stage 1, you're in stage 2, you're at risk. You have to manage your underlying conditions, whether it's blood pressure or blood sugar, whether it's smoking cessation, whether it's, managing your peripheral artery disease, your peripheral venous disease. You have to manage these conditions to the best of your ability so that they don't affect the kidney. You will also be teaching the patient that they probably need to be on high alert, especially as they go into stage 2, that stage 3 is on the horizon, especially if you can't get the blood pressure, the blood sugar under control, that stage 3 is on the horizon. And that's where we do start seeing signs and symptoms of kidney failure. So we're going to teach them about those signs and symptoms. And the first signs and symptoms they're going to see is going to be fluid retention. So that's what we're going to tell the patient to, make sure that you stop your risk factors, control your risk factors, and monitor for any kind of fluid retention, because that's going to be your first sign that your kidneys are going into failure. That's the first sign the patients are going to see. The doctor will probably be, and they need to see their doctor. They need to follow up with the doctor. They need to get their labs as prescribed by their physician, because that's who's monitoring the BUN, the creatinine, and the glomerular filtration rate and the electrolytes. If they never go get their labs, they're not going to know they're in stage 3 until they start having symptoms. If they are seeing their labs trend up, the doctor will probably get more and more involved in making sure they control things. The whole goal is to keep you out of stage 3 and 4 and 5 where we have symptoms. I did put the renal diet here, even though we're introducing it to them. So again, the renal diet is important because it is a low-waste diet. What we recommend is that you introduce it to them in stage 1 and 2, and you enforce it in stage 3 through 5. Stage 1 and 2, their kidneys are still functioning. They can still handle waste. Their BUN and creatinine are not high, but the risk is that they will go into stage 3. So we want to introduce it. And the renal diet is a good diet. It's a healthy diet, but it's hard. It's a hard diet. So let them try it out in stage 1 and 2 before they're being enforced in stage 3 and 4. It's also a good deterrent. Hey, if you move into stage 3, 4, and 5, you're going to have to follow this diet because your kidneys are super damaged. And so sometimes living on this diet is enough to scare you into getting those things under control. This diet is very restrictive if you've ever seen the renal diet. Adequate calories, which, hey, that's a good idea for everyone. Adequate protein, again, probably a good idea for everyone, but a lot of people take extra protein for good reasons. They're trying to do healthy weight, build muscle. But if your kidneys are weak or not that good at processing waste, a high protein diet is pretty toxic to the kidneys because they have to handle a lot of stuff. So the keto diet is a high protein diet. Keto diet didn't exist until, past few decades. And it was never really a big issue, but now everybody wants to burn fat. And so they're like, oh, if we only eat protein and we deprive our body of carbohydrates, then we will burn our fat for energy, which is great. But the waste products from this diet are huge. In fact, on the keto diet, people are measuring their ketones. Ketones are acidic waste products that are when we break down fat into amino acids. When we break down fats into amino acids and energy, we make these acidic ketones. Ketones are bad. We used to never see ketones in diet unless you had diabetic ketoacidosis. But now with the keto diet, we're spilling ketones into our urine. I just need you to know that ketones are ugly for the body. They're terrible. And you should only be on a keto diet if you have adequate kidneys. If you are in stage 1 or 2 of renal failure and you decide to take on the keto diet to improve your health, you can drop yourself into stage 3 very easily because the kidneys cannot handle that much acidic waste products. So, I don't know if you took nutrition as a prerequisite or not, but just a little bit of nutrition and we could talk a little more about it if you have more questions. But adequate protein is the hallmark of the renal diet, not cutting out all protein, just adequate protein. So take a look at your food labels when you get home. 0.8 grams per kilo. Most people are around 80 to 100 kilos. So we're really talking about 60 to 80 grams of protein a day. That's on the renal diet. Now, that's one piece of meat, really, 2 pieces of meat. But when you start adding in beans, lentils, eggs, proteins start to add up pretty quick. And yes, they're healthy. And no, I don't want people to stop eating protein. If they're in the renal diet, adequate protein. The sodium's where people get hung up. Lord have mercy, have you ever tried to do 1,500 milligrams of sodium? Do it for 3 days and then judge your patients. Don't judge your patients that they can't maintain this diet until you've tried this diet yourself. The reason we'll eliminate sodium is, again, water follows sodium around, and as your kidneys start to fail, that renin's being excreted by damaged kidneys, and so they're already having sodium and fluid retention in a damaged kidney. Again, probably not evident in stage 1 and 2, but by stage 3 this becomes symptomatic, and so they will need to limit their sodium in stage 3 through 5. Limiting your phosphorus, because if you have high phosphorus, what do you have? On the calcium side, low calcium. So we're going to limit the phosphorus to keep the phosphorus level down so that we keep our calcium levels up, because we don't want people going into hypocalcemia. So we're going to limit phosphorus just because phosphorus ruins our calcium. Phosphorus is not used in our cardiac or muscle conduction, but calcium is. So let's limit the phosphorus. We're also going to limit potassium because as the kidneys start not being able to excrete these electrolytes, then the potassium level starts to climb, and that will damage our heart as well. So again, let the patient try out the renal diet on stage 1 and 2, and if they hate it and can't comply with it, then maybe they should work on not going into stage 3 through 5, because it is enforced in stage 3 through 5. So that's really all we're doing in stage 1 and 2 is educating, encouraging them to follow their lab work, encouraging them to follow their weights, and reporting any of these signs and symptoms of stage 3 through 5. So stage 3 through 5 is where our kidney is actually injured or failed. So it equivalates to, if you want to put equal signs next to something, stage 1 and 2 of chronic kidney disease is equal to stage 1 of acute kidney injury. We're doing the same kind of things, trying to fix underlying problems. Stage 3 through 5 of chronic kidney disease is equivalent to stage 2 of acute kidney injury. This is where, you know, it's not an acute problem, it's a chronic problem that we couldn't get under control, and now we've lost our kidneys. But the signs and symptoms are going to be almost the same as the same signs and symptoms in acute kidney injury stage 2. So don't really freak out about separating them out. What's the difference between acute and chronic? There are no differences. Once you're in stage 3 through 5, you are going to have the same signs and symptoms as someone going into early and late stages of stage 2 acute chronic injury. Or acute injury, sorry. I'm getting acute and chronic all messed up in my head. The difference is acute kidney injury has a chance to heal. They have a stage 3 and 4. Chronic kidney disease does not have a chance to heal. Once you're in stage 3 through 5, you're either going to stop it in that stage or you're going to progress further. You're never going to be in stage 3 chronic kidney disease and move back to stage 2. That's the sad part about chronic kidney disease is it doesn't heal. So once you're in stage 3 through 5, you're going to have symptoms, and we're just doing symptom management. So basically these expected cues for stage 3 through 5, these are the cues for worsening stage 2 acute kidney injury. This is where we're starting to see actual injury going to damage. And it takes a little bit longer in chronic kidney injury to go through this process than it does in acute kidney injury. But what we're going to see is we're going to see at the very beginning of these stages, the symptoms are mild. As you progress through the stages, the symptoms get more and more severe. So we would expect any of these cues because the kidney jobs are shutting down. So waste product excretion, increased BU and creatinine, same as acute. The itching and the pruritus, this can happen in both chronic and acute, but this is something that happens more towards the later stages when the waste products have built up so much that they've got to get out somehow. They will come out as waste products on your skin. So they always constantly have dry, flaky, itchy skin because you are sweating out through your skin and sweat glands BUN and creatinine. So there's urea on your skin. And it gets worse and worse throughout as you get further. So the itching and pruritus might be light and minimal in stage 3 or 4, but it's pretty severe in late stage 4 and 5. Insulin resistance becomes a problem because actually the kidney secretes any unused insulin. And when the kidney can't secrete insulin, insulin just kind of hangs out in the bloodstream. And just like, someone coming and asking you, the car warranty people that call you nonstop, you're going to stop answering the phone because car warranty people are always at the door. The same thing with insulin. You're going to stop listening to insulin. Insulin's knocking on the door saying, hey, I got some sugar for you. And the cells are like, I'm full, I'm good, go away. And then they eventually stop answering the door. So you get this insulin resistance going on. The kidneys also manage blood pressure. So of course, injured to damaged kidneys secrete renin. Renin turns into aldosterone and angiotensin, which causes vasoconstriction, increased blood pressure, and causes fluid and sodium retention fluid. So we start to see signs and symptoms of that. We start to see signs and symptoms of acid-base electrolyte imbalance. It always goes towards acidosis. This is a metabolic acidosis. The reason for the metabolic acidosis is if we think about our blood vessel, let me go back. I do love drawing little blood vessels. Let's talk about, this is going to be our happy blood vessel. Make you happy. And this is going to be our sad kidney failure blood vessel. So let's draw our blood vessels. We got some blood running through there. We've got some fluid running through there. And that's all good. We got a lot more fluid in the bad, sad one, but we're going to have a lot more fluid running through there. But the important part is what's running, well, not the important part, but one of the things that's running through there. We've got some hydrogen ions, we've got some sodium ions, we've got calcium, we've got, what else? We've got potassium. You notice that most of these electrolytes have a little plus next to them. Plus electrolytes, I'm going to say, if you see a plus next to it, it's an acid. I don't know if you took chemistry. I actually sucked at chemistry, but a plus next to it is acid. So if you have these little acidic byproducts, we just have enough. Your kidney's handling it. It's getting rid of sodium you don't need. It's getting rid of fluid you don't need. It's getting rid of potassium you don't need. But let's talk about our sad little kidneys here, our sad little blood vessels with broken kidneys. This is our kidneys happy, and here's our kidney sad. When your kidney is sad, look what we've got. We've got so much more. We've got tons of potassium. We've got tons of sodium. We've got maybe a little bit of calcium. Depends on how much calcium. We've got calcium in there. We've got lots of hydrogen ions. Lots of those buddies, because the kidney can't excrete them. So what do you think is happening? Look at all these little plus things hanging around here. In fact, they're spilling out. We got so many hanging around because the kidney didn't get rid of it that we become acidotic. Here we have acids in our stream, but they're monitored. The other thing that a happy kidney makes is, I'm going to call this, it's sodium. Let's call it, it's bicarb. Kidneys make bicarb. And what the bicarb does is it joins up with these acids, if they're extras, joins up to them. So look at this, what this bicarb does. If you add hydrogen to bicarb, which is HCO3, let's pretend to do some chemistry here. HCO3, that's bicarb. So these hydrogen ions and the bicarbs, they turn into water. So this neutralizes, the bicarb neutralizes the acids. Well, the sad kidney can't make bicarb. So these hydrogen ions and all these acids are allowed to just run rampant throughout the body, and the body becomes super, super acidotic. So I know you like my little happy and sad kidneys, but I want you to be able to see the screen again too. So most renal failure patients, renal injury, renal failure patients trend towards acidosis, not only because they can't excrete the acids, but we also can't make bicarb to neutralize the acids, so the body tips into acidosis very normal. In stage 3, you are still normal, but you're on the acidic side, and as you move to stage 4 and 5, you become actually acidotic. Frequent infections, because white blood cells can't work in acidic environments. In fact, most of your body doesn't work well in acidic environments. Because our kidneys convert vitamin D, which is involved in calcium absorption, we end up with hypocalcemia, and when you're hypocalcemic, you are hyperphosphatemic. You also are vitamin D deficient as well. And because they stimulate red blood cell productions, patients in stages 3 through 5 are anemic with low red blood cells. We expect this because the kidney's broken, so we have to treat some of these things. Worsening, again, this is just as you move into stage 4 and 5, all these symptoms just become more toxic. The toxins running around, you're not just itchy and scratchy anymore. You can actually have this uremic frost, which is actually high levels, and you see it by his ear here. They have this is your uremic crystals. This is actually uric acid sitting on the skin because it's been frosted out. These uric crystals get in, they create renal stones, they create gout. These renal stones can collect on the heart and cause chest pain and ST elevation. They make you feel sick to your stomach and nauseous because you're just toxic. Some of these toxins can actually cross over and make you feel confused, lethargic, comatose. So you're certainly not going to be that bad in stage 3, but by the time you get to stage 4 and 5, you are getting that bad. Not only are you retaining fluid, but now you're retaining fluid to the point where you have pulmonary edema. So just like if I can remind you of my my lung pictures, Remember, we have retained so much fluid that now fluid is filling into the lung space, and they're starting to build crackles, get short of breath with exertion, maybe short of breath at rest. That's worsening. So like short of breath with exertion is bad, but short of breath with rest and not doing anything is even worse, because we got fluid in our lungs. The pitting edema extends, the metabolic acidosis gets worse, the electrolyte imbalances get worse, and the anemia gets worse. We will continue to monitor everything we were monitoring before, your weights, your BUN, your creatinine, but we have symptoms. The degree of the symptoms is going to be what you're monitoring. Are the lung sounds clear? Are they slightly crackly? Are they full and rails with pink frothy sputum? There's degrees of how bad your lung sounds are. Your level of consciousness, no problems versus just irritable and headachy versus actually lethargic and comatose. Blood pressure could be normal, could be slightly elevated. Your cardiac rhythm is going to be dependent on your electrolytes, but they will get worse and worse as your electrolytes get worse. The daily weights will continue to increase because you're retaining more and more fluid. We're going to symptom manage these things, okay? For waste product toxin excretion, well, we can't just reach in there and grab those things. So if you're having existing cues, meaning that you're not that bad, you just exist, you're probably in stage 3 or 4, we're going to make sure you get the renal diet. No more waste, okay? Cut all that out. We're going to cut down on the protein. We're going to cut down on the phosphorus. We're going to cut down on the potassium. Blood sugar control, keep managing those things. Keep managing those underlying conditions, blood pressure management. Well, that's on the next slide. But the waste management, we're really going to follow mostly with the renal diet. Toxins that are circulating around in the bloodstream also irritate the nerves. I probably should have put that in the cues. Peripheral neuropathy starts to happen in stage 3 through 5 because these toxins circulating around actually irritate and damage your peripheral nerves, and so they can have peripheral neuropathy. You hear that diabetic patients get peripheral neuropathy. The high blood sugar damages the nerves. Well, high levels of BUN and creatinine also damage the nerves and get peripheral neuropathy. So if you have chronic kidney disease from uncontrolled diabetes, you can imagine the level of peripheral neuropathy that these patients have. And that is due to the extra waste damaging the nerves. Blood pressure, still maintaining your blood pressure medications, fluid restrictions, diuretics if the kidneys will listen, and continuing to monitor your daily weights. If your potassium is high, you can take K-oxalate. We are going to make sure that you get calcium, vitamin D supplements, but you are going to make sure that they are absorbable and that we are going to keep our phosphate level low so that we can continue to absorb calcium, because if our phosphate level gets high, we're not going to absorb calcium. Managing the red blood cell production, we actually have a replacement for that hormone. We have no way yet, well, we can replace the waste product excretion. We do that with dialysis. We don't really have anything to manage blood pressure and fluid balance other than fluid restriction and antihypertensive meds, because there is no way we can manage that other than dialysis. And we're trying to keep people off of dialysis in the early stages here. In stages 3 and 4, we're trying to keep you off of dialysis and manage the symptoms. But really, dialysis is going to be where you're going to go if these symptoms get worse. But we can replace one hormone. So there is some good news. A lot of patients with low hemoglobins or red blood cells or anemia do get erythropoietin, which is the hormone the kidney is supposed to produce. But since it doesn't produce it anymore, we can actually give it. So erythropoietin is given as a shot. I think they give it as a shot every 3 to 7 days, depending on how often you need that hormone to stimulate red blood cells and prevent anemia. But if you have worsening cues, you have moved into the dialysis realm, because that's the only way we can replace the kidney is with dialysis. Fluid restriction, you've probably learned about fluid restriction in block 1, but I did want to point out that fluids are any liquid that melts anything that is liquid at room temperature. So that does include popsicles, jello, puddings, ice cream. popsicles, things that people think they can eat, and they're like, well, it's not a drink. Well, just because you don't drink it through a straw doesn't mean it's not a liquid. Soups, ice cubes, all that stuff adds up. And if they're, this is kind of a general, again, a fluid restriction is ordered by the physician. These are general guidelines. We're not going to go ahead and put these orders in the chart ourselves. But if our patient's not producing any urine and they're not on dialysis, there's no way for the fluid to get out of the body. We're going to limit their fluid intake, guys. Maybe we're not going to enforce 1,000 milliliters a day unless the doctor recommends it, but we can certainly not allow the patient to be chugging liters and liters of hydro flasks or sodas or drinks, or just having a clear liquid diet where they're just eating 3,000 milliliters of liquids a day. We're going to start kind of telling them, you need to limit it. And I love the puffer fish up here. He is my favorite. Look at him. Why? This is your patient. He looks like a Michelin man in the bed. And he's like, I'm thirsty. Give me fluids. And you're like, no, you're not getting any more fluids. Sorry, buddy. There's nowhere for it to come out. You can't take it in if it's not going to come out. So these are just some fluid restriction tips for you. Keep going. These, I'm going to let you read through. This is the pharmacology thing. Again, phosphate binders are very common in patients stage 3 through 5 because we are now having electrolyte imbalance. We do have hypocalcemia and vitamin D deficiency, and we don't want to have hypocalcemia because when the body is hypocalcemic and it can't get calcium from its dietary needs, it will break down its bones and you will get frail, brittle bones and broken bones and fractures. If you are constantly hypocalcemic, it will pull it from the bones and you will lose your bones, and they will have, and that's why patients with chronic renal failure who aren't managing themselves well do have frequent fractures because they are constantly hypocalcemic because their kidneys can't convert calcium. So we want to give them dietary calcium that they can take, and we also want to keep their phosphorus under control because of that inverse seesaw. So we want to keep our phosphorus low so that our calcium stays high. The most common are the aluminum-free, calcium-free phosphorus binders or the calcium-based phosphorus binders. Aluminum-based ones, actually, we can just take these off. They used to exist, but we don't use them anymore. Aluminum is toxic to the brain, so we don't give those anymore. And depending on what electrolyte they are low on, they may decide calcium or magnesium based, but the goal is to keep phosphorus low. Erythropoietin, again, is a IV or subcutaneous injection that is usually given 1 to 3 times a week, depending on their hemoglobin levels. And again, if you don't need it, you don't need to take it. If their hemoglobin levels are high and they're not anemic, they don't need to be stimulated to make more red blood cells. But most patients are anemic and they do get erythropoietin. That is the hormone that the kidney is supposed to make, but we made it in a lab for them. Gabapentin is for peripheral neuropathy. You probably have a lot of patients that were going to be on gabapentin. Gabapentin is for any peripheral neuropathy, any nerve pain, whether it's diabetic related, kidney failure related, heart failure related. If you have peripheral neuropathy, which is pins and needles, or no sensation. So when the nerve starts to die, it sends wrong signals and you get pins and needles on your feet, kind of like if your foot falls asleep or your arm falls asleep, that pins and needles feeling. They have that pins and needles feeling all the time because the nerve is damaged. A dead nerve doesn't conduct at all. There will be numbness, but as the nerve is damaged and dying, it will have pins and needles sensation, which is very, very frustrating to the patient. So gabapentin is supposed to help with nerve pain. Statins are a good idea for probably everybody in the planet, but certainly patients with kidney disease have higher levels of cholesterol, and they'll keep the cholesterol under control. And basically during stage 4, you've got to manage those risk factors, keep those underlying conditions under control, because you're just going to progress further into stage 4 and 5 if you do not. If you didn't control them in stage 1 and 2, stage 3 and 4, where you can try to get it under control again. But again, remember, chronic kidney disease does not have healing stages. Chronic kidney disease, just if you can get things under control, you stall it at that stage. You want to avoid end-stage disease, which is the need for dialysis. So enforcing the renal diet, reporting worsening cues to the provider, and then starting to think about what dialysis they would be interested in, if any at all. There are two choices for dialysis. We'll talk about that in the next slides. There is peritoneal dialysis and hemodialysis. There's also the choice to not have dialysis. If this patient has been fighting chronic kidney disease for years and years and years and can't manage their illnesses, can't manage this, they may choose not to do dialysis at all. But remember, dialysis is our only way to replace the kidney, and in your worsening conditions in the stage 3 through 5, you will need to replace the kidney with dialysis, and some patients may not want it. That is a conversation to have before you get into the end stages. So that is your teaching. Let's talk about dialysis. You want to go out and walk the dog again, get another cup of coffee, go ahead and hit pause on the thing, and I'll see you in a minute. If you stuck with me or you came back from your bathroom break, welcome back. We are talking about dialysis. This video, again, I'm not your only instructor. Go talk to people on the internet. They got lots of information. Just make sure they're good sources. So I try to give you some good sources here that are good to watch. This one is, yeah, I know it's up to date. I would like to go to YouTube. I don't know, my link's not working here. Let's see. Let's see if it'll let me do it again. I think the link works. I think it's just a problem with my thing. So you might have to copy paste the link to get it to work. I'm not really sure why it is doing that. Let's see. The link is listed there. If you can copy it. I think if you're not in screen mode, I think you can. If you're in the PowerPoint, I think you can get to it. Let's see. I just want to see if this works. Sorry about the pause here. Ugh. All right. Well, I'm going to have to copy paste the link. It's a great video. Maybe I will link it on my YouTube channel. I think I'm going to put it in my YouTube channel. I'll link the video in the YouTube channel. So go to the YouTube channel where you got these recordings, and you will be able to access that video. I'll put the link there. They're going to get a choice, so they can choose no dialysis, remember that, but if they're going to choose a dialysis, there are two kinds, peritoneal and hemodialysis. This is kind of a brief summary slide about it, but let's talk about each one. Peritoneal dialysis is a at-home, patient does at home. It needs to be for someone who is very independent, very compliant with their treatments, because it involves putting a surgical catheter into the abdomen and using the abdomen's peritoneal membrane as a kidney. So this surgical catheter and the patient's peritoneal membrane become their kidney. The way it does this is that you put some thick fluid. So remember, we're talking about fluid shifting. We want to mimic what the kidney does. What the kidney does is it dumps everything into waste and then pulls back what it needs. So we're going to try and do that to the best of our ability. We're going to put this thick fluid, this dialysate fluid. Dialysate is the fluid that we put into the body. And that fluid is really, really thick. It's full of bicarbonate. It's got sugars in it. It's got a ton of stuff in there to attract things, because the peritoneal membrane is the membrane that surrounds your gut. And so there are lots of blood vessels absorbing things from the intestines. And these blood vessels are also running around the peritoneal membrane. So as this thick fluid sits in the membrane, so you know what I'm going to draw again. Let's go to a whiteboard. We love drawing. And I'm just going to show you. You don't have to draw well. Let's draw a little peritoneal blood vessel. So here's a blood vessel. So we're going to put BV because that's a blood vessel. And it is sitting on top, and I'm going to draw the peritoneal membrane as yellow. So here's your peritoneal membrane. And the blood vessels are sitting here, and you got your, these are intestines. And you got your blood vessels, and the blood vessels are running past the intestines, and they're absorbing things from the intestines. And this peritoneal membrane is just holding all of our intestines in place. But what we are going to do now is we're going to infuse some dialysate. So let me see what color I want to make my dialysate. Let's make it green.
So we are going to insert, I'm a doctor now, I'm going to give myself a promotion, and I'm going to put a catheter into this space through the peritoneal membrane here. And, oops, I put it in too far. This is why I'm not a doctor. Let's put the catheter into the space. So it's in the peritoneal space, which is this space right here. So this is the space that we're aiming for here. There's the peritoneal membrane, there's your blood vessels, and then we have a little space here. So now we're going to take from that catheter and we're going to infuse dialysate in here. So the dialysate is going to go into your abdominal area and it's going to sit there. Now the blood vessels are coursing by and they're absorbing stuff from the intestines, but they're going to see all of this stuff that's sitting in here. Remember, this stuff has a ton of bicarbonate in there, right? We're going to call it bicarb. This has tons of bicarbonate in it, and it is thick. We're just going to call it thick. This is some thick, juicy stuff. It's like putting syrup in there. So what is going to be attracted to this thick stuff? Well, water. Water is going to be attracted. It's like, ooh, let's go there. Because remember, there's lots of water. You're in kidney failure. So in this blood vessel is a ton of water, is a ton of sodium, potassium, tons of hydrogen ions, tons of stuff sitting in here. That's all attracted to the dialysate. It's like, ooh, I'm going to go and neutralize in here. I'm going to go to the bicarb. I'm going to go in there. So all this stuff that we don't want in the bloodstream, all this extra fluid, all this extra hydrogen ions, all that stuff will get attracted to the dialysate. Then when we open up the drain that we put in, so we infuse dialysate into the membrane, and then we open up the drain and that dialysate drains out, and we are left with, after the dialysate drains out, so let me see, take this back. So we're going to take the dialysate back out, undo all this, and say goodbye to the dialysate. It's like, so it's already attracted all those hydrogen ions, and it's attracted all that fluid and water, and then we take dialysate out of the system. And once we drain that dialysate out, what's left in here is less fluid and less of those you got a couple hydrogen ions and a couple of sodiums, a couple of potassiums, but most of it has left the body, which is what we wanted from the kidney in the first place. So peritoneal dialysis uses that peritoneal membrane to hold in the dialysate and allows this exchange to happen across the blood vessels in the abdomen. So the inflow part is where we infuse this dialysate into the abdomen, takes about 10 minutes. The dwell time is where the dialysate sits there and attracts things out of the blood vessels. It's like, here, acids, come in here. Oh, urea, come over here. You want to come here where the bicarb is. And it pulls stuff across, and then we pull all that junky waste out and drain it into the drainage bag. So it's pretty easy. It works really well. But the patients have to maintain this. And you can see a lot of this is done automatically on a peritoneal dialysis machine at home. They're in charge of their site care where this catheter is. And they are not putting anything in there except dialysate fluid and dialysate drainage. Otherwise, this catheter stays capped, clean, sterile as they can make it. Again, this is their kidney. So the skin around there should be soft and non-tender, non-infected. A little bit of mucus discharge is fine, but not green or yellow purulent pus. When they put the dialysate fluid in, it might feel like you kind of ate like a big turkey dinner. You'll feel a little bloated and full, but it is not painful. It should never be painful. Painful is a sign of an infection. So that is always a big no-no. You feel full, but not pain. So during that dwell time, especially if you're using a lot of dialysate,
you are putting stuff in there, so it might be a little short of breath with activity, but again, bloating is normal, pain is not normal. Then when it drains, this dialysate goes in clear, comes out looking yellowy, because what did we pull into it? We pulled in urea, we pulled in creatinine, we pulled in acids, we pulled in all the things that the kidney would have excreted, so it looks yellow, and it should look just like urine. It looks exactly like urine. It's pale yellow and clear, not cloudy, not sedimenty, clear. So because this is around the gut and the peritoneal membrane is very porous and the blood vessels are very porous, there is small amounts of protein lost every time you drain the dialysate. So they are the one exception. If you're on peritoneal dialysis and you're in stage like 5 with peritoneal dialysis, they're not on the protein restriction because their dialysis causes some extra protein loss. So peritoneal dialysis patients do not need to deal with the protein restriction because they're constantly getting dialysis. They do this dialysis multiple times a day. This is not like hemodialysis where you go to a center and do it once a week, or 3 times a week or 2 times a week. This is done on a daily basis, and most patients do it. I don't think I have on here. Most patients will set it up at night and run their exchanges at night. So their kidney doctor will talk to them about what their how many exchanges they're supposed to do, how long the dwell time should be, the makeup of the dialysis. They're working on this very closely with their renal doctor and their renal and their dialysis team. But they prescribe a set number of exchanges with a certain amount of dialysis, and they can do them, here and there throughout the day, but most of them are done at night. So they'll hook themselves up to this dialysis machine and clean out their blood throughout the evening, and then they cap it all off in the morning and they go about their daily business. But it does need to be done on a daily basis, and it does need to be done pretty continuously. And it's just much more normal than hemodialysis, much gentler to the body, and altogether better. But again, this requires your patient to be highly competent, highly compliant with their medical team, with their medical care, and maintaining an infection-free environment. So this is not appropriate for patients who cannot do that. Maybe they are old, maybe they're elderly, maybe they got other comorbidities, maybe they don't have a good support system, maybe they just cannot handle doing all this work on their own. So it is better for the body, but it is a choice between the patient and the physicians what kind of dialysis they're going to get. The number one complication of peritoneal dialysis is infection. We have a catheter right into the bladder, and we are infusing and draining. Whenever you hook something up to a system and put it into your body, you have a risk of infection on it. So if a patient gets infected while on peritoneal dialysis, they have lost their kidney. And that is a big complication. So the signs of infection when you're on peritoneal dialysis is cloudy peritoneal drainage. So very similar to if you have a UTI, cloudy, foul-smelling urine is a sign of a urinary tract infection. Cloudy, foul-smelling dialysate drainage is a sign of a peritoneal infection. Any abdominal pain during or after dwell time could be a sign of a peritonitis or an infection of that membrane. A firm, rigid abdomen, increased temperature, increased white blood cells, or pain around the catheter or pus, signs of infection. They need to not do dialysis. They need to talk to their doctor immediately, because what is going to happen is they cannot use their peritoneal catheter while the membrane is infected. They will have to switch over to temporary dialysis if the infection is bad enough that they cannot use their peritoneal membrane. So patients who are taking peritoneal dialysis at home are very serious about keeping their peritoneal catheter and their equipment and their supplies clean. If your patient cannot maintain that and they have 1 or 2 or 3 infections, or they're getting frequent infections on peritoneal dialysis, the team will decide that that's probably not the right dialysis for them, and they will be transitioned to hemodialysis. But if it's just a one-time, a random occurrence, they will let the peritoneal membrane heal, do temporary dialysis in the meantime, and then they can go back to regular peritoneal dialysis once their membrane has healed. There's also a chance we keep putting large amounts of fluid into the abdomen. You can get a hernia. So any protrusion around the groin, the umbilicus, the scrotal area. The peritoneal membrane is your whole abdominal membrane. So if the if any of the membrane starts outpouching or whatever, some of that fluid can scoot around. And when you're standing up, walking around, or sleeping, that fluid is dependent. So sometimes they may see it as hemorrhoids, they may see it as groin edema, but any protrusions or hernias should be looked at by the team because that means that your peritoneal membrane could be bad. If it's not treated, you can get a membrane leak, which means that as you put dialysate into the abdomen, it actually leaks out of the abdomen into another area. Again, that is a broken membrane. They will have to pause their peritoneal dialysis while that membrane heals. So for any of those complications, they need to notify their provider because they will need to talk to them about their next steps. They will be taking care of their own peritoneal catheter. Yes, it is clean. In the hospital, it's sterile because we are going in between patients and we don't want to cross-contaminate. At home, when they're taking care of their own things, it is soap and water and as clean as possible. They can clean their catheter with antibacterial soap and cleanser, rinse it, dry it, and keep it just covered with sterile gauze. It doesn't need fancy dressings, but just trying to keep it clean and covered so that it does not get infected. Hemodialysis. Hemodialysis is what we pretty commonly hear about. We think it's, hemodialysis is a little rougher on the body, but it is completely passive for the patient and is done by the dialysis team. So the patient doesn't have to be involved. They just go make their appointments 2 to 3 times a week, sit in a chair, get their blood cleaned out, and then they go home. There are a couple issues with hemodialysis. I'm not going to go over completely how it works. I would certainly, if you are in clinical, please talk to dialysis nurses. They are amazing. If you are in clinical and your patient is on dialysis, please go talk to the dialysis nurse. They are lovely. They are so helpful. And they can really give you a lot of detail about what they're putting into the patient, what they're monitoring, what they're watching. It's a great, so any patient on the floor that's getting dialysis, go talk to that nurse. Not the nurse that's caring for the patient, but the nurse that's caring for the dialysis machine. There are specialized dialysis nurses, which is why we are not teaching you the procedure about hemodialysis, just what to expect and what not to expect. But dialysis does involve cannulating a large vessel, taking the blood out of the body, putting it through a blood pump where it then meets up with the dialysis. So in peritoneal dialysis, we're putting the dialysate into the abdomen and letting it exchange there. In hemodialysis, you're taking the blood out of the body and letting it exchange in a filter in a machine. So a little bit of a difference. In order to get the blood out of the body and to the machine, you need an access port. So if they're going to be on long-term hemodialysis, the two access ports are a fistula or a graft. These are surgically implanted, and the important thing to know about these is that they are actual surgical interventions, and they will take about a month or 2 to be ready to use. So you can't just decide, I'm going to start dialysis on Friday and I'm going to go in and get my AV fistula on Monday and be ready to use it by Friday. The AV fistulas do take time to mature and so that we can use them to pull blood out of. The dialysis catheter is a central line catheter. That is put in a large central vein. Doesn't need time to mature because it's already in a large central vein. And that one can be, but it's a central line. The other two, the fistula and the graft, are not central lines. They are artificially large veins that the surgeon has made that tolerate many, many venipunctures and actually have, we just made them a thick vein that's not as centrally located. A dialysis catheter, a temporary hemodialysis catheter in the central vein is considered a central line and has a very, very high risk of infection. But it can be easily removed. So this is the catheter that is used for patients that are getting dialysis temporarily. So if your acute kidney failure patient, your stage 2 worsening patient needs dialysis, they're not going to put in something that's going to take 2 months to use. They're going to put in a central line catheter because we can use it right away and it can be removed when you're done with it.
But because of the high risk of infection, dislodgement, bleeding, if you bleed out of that catheter, you're bleeding out your whole central circulation. So they're high-risk catheters. We're not going to use them for just standard yearly, for your 3-day-a-week hemodialysis. They're going to get something a little more permanent, which is a fistula and a graft. So what we expect when they go to get put on this machine is we expect them to have an intact and functioning access. So if they have a surgically implanted, and what they do when they put these fistulas and grafts in is they, I don't know, let's see if I can blow this up. They actually take an artery and a vein, and do you see down here where they have put together the artery and the vein? So they basically take this vein and anastomosis or connect it with an artery, which makes, let me draw another picture. Let's talk, this is a vein, and let's put the artery here. Let's make it red, and we're going to put the artery here. So if this vein is attached to this artery, trying to draw here, and let's see, how do I want to draw this? I'm having trouble with my colors here. Okay, so basically when blood pumps through this, it creates like a little whirlpool right here because some arterial blood mixes with the venous blood here, and it creates like this big whirlpooling eddy, which over time thickens the wall, scars the wall, because the vein isn't used to the blood pressure from the artery. It's like, holy moly. So it starts thickening its wall to deal with this extra pressure. And in that area where there's extra pressure, this wall gets super, 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 super thick. And that vein can now start, and it's called a fistula, where this area has come together and created turbulent blood flow to thicken this wall. So this wall becomes super thick, and that's where we can put catheters in. It tolerates, it's a strong vein. It's basically turning one of our wimpy little weak peripheral veins into something strong like a central vein. So a graft takes a while to get to this point. It takes about 2 months to get to this point. So that's kind of what a graft is in there doing. And so when they puncture a needle in, and let me see if I can blow this up again, but they will put one needle in to pull blood out. So this is going to be the blood going to the dialysis machine. So right here, we got the blood going to the dialysis machine. So blood's coming out, going to circulate through the dialysis machine, cleaned all out, and then get put back into the body to continue moving around the cleaned out blood. So it needs to be able to withstand the huge suction of the pump that is pulling blood out. So these veins need to be pretty thick and pretty resilient. So a fistula works great. If for some reason maybe you have peripheral vascular disease, or you're not that great of a vein, or they looked at your veins and they're like, none of these veins are any good, they can put a synthetic graft in. It's a silicone self-sealing graft, kind of like the IV tubings or not IV tubings, but like drains or something. They're self-sealing silicone, and you can put needles in them multiple times and it'll seal themselves back up. But the issue with this graft can hold tons of pressure. It can it can hold the pressures that the dialysis machine is trying to suck out of the body. It can tolerate multiple, but it's much, much more likely, because it's synthetic and it's not our own body, the immune system will attack it and break it down over time. So it is more likely to clot off and break down and fail. So there are issues with both of these, but we do want to make sure before they get their dialysis that their access is intact. Because they've surgically created a new vein, you are not allowed, or put in a synthetic vein, you're not allowed to do any IVs, blood draws, or blood pressures in the extremity with your AV graft. If it's the functioning AV graft. Now, some people have had multiple grafts in. One will go, because they do clot off, they do scar off, they do have issues. They're not going to go in and remove them and take them out. They just kind of leave them. So this patient here with that big, you can see the thickened the thickened vessel on his arm, and that is his graft. Some people have these thickened areas, and they'll be like, "Oh, that's a fistula that doesn't work anymore," and they don't use that for dialysis, and they made another one. You may use an arm with an old fistula in it for blood draws and blood pressures, but if it's your active sorry, let me make that smaller again for you. If it is your active graft or fistula, you are not, I don't know what I did here. Hang on. Okay, sorry, I had to fix my computer there. All right, let's get it back on the main screen. So make sure that you are not doing blood draws, blood pressures in the extremity with your active graft or fistula, because you can ruin it, and you do not want to come across a renal doc when you've ruined their graft or fistula or surgical work. So no, just make sure no blood draws, no blood pressures, no IVs in that extremity. AV grafts and fistulas should have bruits and thrills. So auscultate means listen to. So listen to that big bulbous area, and what you're listening for is that turbulent blood flow, and it's called a bruit, and it sounds like what you would expect a whirlpool sound to sound like. So if you have any patients in your clinicals that are on dialysis, please go ask them if you can listen to their graft. Put your stethoscope on their on that big swollen vein there, and listen for the washing machine sound that is a bruit. When you feel that that big bulging vein, that graft or that fistula, when you feel it, you will feel the turbulent blood flow, and they call it a thrill, but it feels like a humming. It's not a sound, but if you put your finger on it, it vibrates. If you put your finger on a vein, it doesn't vibrate, right? You put your finger on an artery, it pulses. Well, on an AV graft, it vibrates under your finger, and that's a thrill. It's a thrill to feel the thrill. So anyway, if you do get a chance in clinical to have a patient that has dialysis or a patient who's on dialysis, please go in and ask if you can auscultate the bruit and palpate the thrill. Go have that thrill. And you're always also going to want to keep an eye on the fingers and the circulation of the distal extremity. So if they have it in their right upper arm, you're going to keep an eye on the cap refill and the pulses of the right hand, because you want to make sure that circulation is good. Because if you look at what they've anastomosed there, they should have left some functioning arteries and veins there, but you want to make sure that blood flow out to the extremity is good. So make sure that the hemodialysis access is intact. Of course, the dialysis nurse will check that before they hook them up for dialysis, but that is your job as a nurse taking care of the patient, even in the office or in the hospital, is making sure that their access is good. Strict intake and output, including weight prior to and post. Remember, weight is our great way of telling our interstitial blood volume or our edema amount. So when they pull fluid off of the patient from hemodialysis, we want to know exactly how much weight they lost. So they need a weight prior to and post dialysis. Disequilibrium syndrome is expected. Now, remember I told you peritoneal dialysis is a little gentler on the body, a little more normal. What you're doing with hemodialysis is patients go 2 or 3 days in between dialysis appointments. So what's building up in their systems in between appointments? Waste products, acidosis, urea, nitrogen, all these nasty things are building up in our in the bloodstream of these dialysis patients. So, and also fluids are building up. Fluids got nowhere to go. You're end-stage renal disease, you're waiting for dialysis appointment. If they're not following the renal diet, which patients who aren't compliant all along and have gotten to end stage, not because they didn't mean to be compliant, but sometimes patients just can't follow their recommendations. They weren't following the renal diet. They weren't managing their diseases. If they're not managing their renal diet, they're going to become more toxic in between dialysis appointments. The more toxic you are when you go into your hemodialysis, the rougher the body's going to have, because instead of doing this on a daily basis, cleaning out your blood, you're doing it on a 2 or 3 time a week basis, which means the body is losing like 3 to 4 liters of fluid at a time, plus going from acidosis to normal. That shakes up a body, and it is just it just causes a little bit of discombobulation, disequilibrium. So it's just the body's adjustment to having rapid removal of vascular volume and acids and electrolytes. And the way the body responds to that is, if you can imagine, you get kind of nauseous, you get kind of muscle cramps and tremors because your fluids and your electrolytes are shifting all over the place. Nothing's settled back into place yet. What it's going to do is it's going to pull volume out of the bloodstream. So for the first few hours after dialysis, you are hypovolemic, but in the meantime, fluids will shift from the tissues into the bloodstream from all that space that now has left in the bloodstream. But in those couple of hours, your body's a little disequilibrium. So we expect you to be a little off kilter after dialysis and not feel that great. So the blood pressure might be a little lower until fluid pulls in from the tissues to fill the vessels again. Your heart rate might be a little higher until fluids fill in from the tissues to fill in the blood vessels again. And again, because of the electrolyte changes, you could have dizziness, blurred vision, and headaches, cramps. We expect that. We will monitor it and make sure that they do equilibrate after time. They should re-equilibrate within 4 to 8 hours. If they are lasting longer than that, then we have a problem. So we do expect it, but we don't like it, and it doesn't make us happy, and it doesn't make the patient happy. We will monitor it. We don't expect bleeding from we expect that the access site, remember, they just put 2 needles into a very large turbulent vein and then sucked a lot of fluid out of it. And then they're going to take the needles out and they're going to hold pressure on it for a little while. If the bleeding is controlled with a pressure dressing, that's perfectly fine. It's a big vein. Whenever you take something out of a big vein, you got to hold pressure on it, right? Also, whenever you take fluid or blood out of the body, it has a higher risk of clotting, especially when you pull it through a pump and you start breaking platelets and things like that. There's a high risk of clots. So they do use heparin in the blood dialysis machine, and that also increases your risk of needing a pressure dressing for longer or bleeding longer. So just keep an eye on the access site after hemodialysis to make sure it's not bleeding through that pressure dressing that the dialysis nurses put on. One more thing to say about meds. If your patient is scheduled for dialysis at 9 a.m. and you have a bunch of 9 a.m. meds and you give them all their 9 a.m. meds and then say, bye-bye, have a fun dialysis, guess where all those meds go? They go into the dialysis machine, and they get thrown out of the body because they basically get cleaned out. So if your meds are due the hour before, or if they're due during dialysis, double check with pharmacy or your provider whether you should hold them until after dialysis, because basically you don't want to give them a med and charge them for a med and then it just gets removed from the body in dialysis. So important meds usually get rescheduled to after dialysis, but doctors and pharmacists don't know when your patient's scheduled for dialysis, so that's something that we generally do, is know that if they're going to dialysis at 11 o'clock or noon, that maybe, if the meds, and that's also a good reason to know your peak and duration doses of these meds, because if you give a med at 8 and it's already processed through the system before dialysis, then it's fine to give it. But if it's going to be processing still through the system and still active during dialysis, you may want to question whether you want to hold it till later, because it will get dialyzed out with dialysis. Just think how much you're learning. What we do not expect after hemodialysis is that during dialysis, the dialysis machine, when it's pulling blood out of that big vein to put it through the machine, we don't want it stealing blood from our extremities. Remember, we're supposed to have still some other arteries supplying blood to our hands if they have grafts in their arms. But we don't want dialysis machines stealing blood from the extremities. So if your patient starts complaining during dialysis or immediately afterwards of numbness or tingling or coldness in their hands that gets worse they're on dialysis, they might have arterial steal syndrome, and that should be something that the physician is aware of, because that's something that you don't want to leave them on dialysis for 3 hours and deprive their hand of circulation for 3 hours. That's something you would want to notify the physician of. It is something that's going to require a surgical revision of their AV graft, so it is something you need to notify a physician of. Worsening disequilibrium syndrome is that it's so bad that your blood pressure is less than 90, or it's so bad that your heart rate's greater than 110, that you could have seizures, altered level of consciousness, or if it lasts longer than 8 hours. All those things are things where you should go ahead and call your provider, because that's not expected disequilibrium. That's
really bad disequilibrium, and we want to intervene with that. Excessive bleeding from the site or bleeding through a pressure dressing is something we do not expect, and you'd want to call a doc because they're probably going to get PT, PTTs, double check the heparin, figure out what's going on, and you probably need extra help in the room anyway if your patient is bleeding from a pressure dressing. So if you're excessive bleeding from the site, go ahead and stay in the room, hold pressure on that site manually, and get someone to notify the physician and let them know that you are bleeding from the site. And then infection, of course, is a risk of any invasive procedure. Kidney transplant, I just put this here mostly for your information. Kidney transplant is the best treatment for end-stage renal disease, but there just aren't enough of them. So they are fewer than 25% of the people that request a kidney actually get a kidney. You can get kidneys from multiple places. You can get them from organ donation. You can get them from relatives with the same blood type. You can get them from paired donations from some people just donate their kidneys to anyone that needs them. I mean, oh my gosh, I wish I was that altruistic. Really, there is no difference between this and a regular nephrectomy if you study nephrectomies for your post-procedure care, but there is an extra complication of organ rejection because you're putting in someone else's organ. And I like the picture down here because I think it's interesting. They keep your old diseased kidneys just in there, and you get a third kidney. So you get like a little bonus. They don't take out your old kidney and put it in the new kidney in its place. They just leave your kidneys where they are, the dead shriveled little guys that they are, and they put in a fresh new kidney in there and put in all new vessels and everything. So I thought that was kind of cool. But because it's not yours, the immune system will constantly try to kill it and remove it from your system. So the number one, and patients will be on anti-rejection meds to prevent this from happening. But if sometimes the immune system can even override the anti-rejection meds and reject the organ, which is basically signs of renal failure because they've killed off the organ and you have no more kidney again. So that's one more complication other than regular nephrectomy or urinary procedure, post-procedure care. So you have survived the renal failure lecture. I will see you in class and we will go over some questions. And please, again, always email me or call me or text me if you have any questions on the content or if you're working through anything. And I'll see you in class.